We didn't go to coder school. We didn't go to provider school. We went to doctor school, medical school. We didn't sign up for this. We didn't sign up for this. My career satisfaction depends on the satisfactory hours I spend with my patients, on the outcomes that I get when I treat somebody. That gives me satisfaction.
We are all multi-millionaires. I mean, I don't know about you, but I have a money tree in my office. I mean, I can pay $100 bills. I mean, that's the perception. Hi, everyone. I'm Dr. Eloy Roman, and I am a board-certified hematologist oncologist. And it is no secret that us doctors are afraid of medical malpractice lawsuits. Okay, and unfortunately, this leads us to perform a lot of unnecessary testing, which does one of two things. It increases healthcare costs, and it can also perform unnecessary tests in our patients. So to discuss this, I have with me not only a dear colleague, but also a friend of mine, Dr. Manrique Iriarte. So Dr. Iriarte, welcome to the program, and tell us a little bit about yourself.
Hello, thank you very much for having me here. I'm an internal medicine physician, board certified internal medicine. Currently, I practice medicine in the outpatient setting in Naples, and I have an interest in health communication, healthcare policy, and I'm delighted to be here with you.
Excellent. So, I mean, I guess it's no secret to say that you and I are infantry. I mean, we're on the front lines of patient care. I mean, we are seeing patients every day. So that's the reason that we both collaborated in this video, because this whole topic of tort reform is quite controversial. But in my opinion, it doesn't have to be. I mean, it's no secret that because of lawsuits, we are performing a lot of unnecessary tests. I mean, would you agree with that?
I wouldn't say not only unnecessary tests, but unnecessary procedures, unnecessary hospitalizations. It's about the intensity of care from fear of being sued, basically. In my mind, and I would say in any active practitioner's mind, there is no question that the fear of being liable for something will lead to increased intensity of care that most of the times it's not only unnecessary, but a lot of times also harmful for the patient.
I 100% agree. I mean, I call it bad medicine. Unfortunately, I don't know if you feel the same, but a lot of times I feel that my arm is twisted into performing these tests because, it's considered a community standard. And I guess it really depends on where it is that you're practicing. I mean, just to prove this point, if you're okay with this, I want to present a case to you that I recently was involved in, which proves this point precisely. I was recently called by one of our colleagues that they had a patient in their office that presented with lower extremity swelling. So one of their legs was swollen, basically. Of course, we see this. We're thinking about DVT, the deep vein thrombosis. So this patient had a Doppler ultrasound, and yes, it was confirmed that this patient has a blood clot in the leg. So the doctor called me as a hematologist. What do I recommend that he do? I basically told him, listen, if the patient is stable, looks good, their vital signs are good, their blood pressure is fine, you can simply place them on blood thinners and send them home and just, educate the patient on what they have and the possible risks. And the doctor told me, you know what? I do not feel comfortable doing that because can you, and his words were, quote, can you confirm, is it 100% that this patient is not going to have a pulmonary embolism within the next 24 hours or as soon as they get home? And of course, I mean, I cannot confirm this. I don't have a magic or a crystal ball telling me what's going to happen. So the doctor told me, you know what? I do not feel comfortable sending this patient home. So patient was sent to the hospital. And of course, we know this because we see it all the time. When they got to the hospital, they repeated a lower extremity Doppler. They did a ton of blood tests. They performed a CT angiogram to the patient, which did not reveal a pulmonary embolism. And there you go. It leads to this whole array of testing that, number one, in my opinion, was completely unnecessary. And in this case, for example, this patient had a CT angiogram where this patient was given intravenous contrast, the potential risks, which unlikely, but it can also damage their kidneys. The millisieverts of radiation they were exposed to with this test. I mean, in my opinion, all unnecessary. I mean, and again, this is because of the fear of lawsuits. I mean, do you see this in your area where you practice?
All the time. You hit it right on the nerve. And this brings us to a broader point, because in that particular example that you're telling me, we both know that uncomplicated DVT in a patient with manageable symptoms, the percentage of these patients that will go on to develop a clinically significant pulmonary embolism, it's low. Yeah, you can develop, 1/3 of them will develop clinically insignificant PEs. But what science tells us, and this is actually a statement by the American Society of Hematology that I am sure you're much more familiar with than myself, the outcomes with treating this patient at home are much better. And this is probably related to the fact that when you get hospitalized, the immobility issues, the nosocomial infections, and people do better if you treat this DVT at home. But because of that fear, because of that way of shifting the liability to a tertiary center, the physicians tend to be defensive. And when this patient gets to the hospital, in that CT angiogram, they find a solitary sub-centimeter pulmonary nodule. Then you bring the pulmonologist in. All right. What is this? Is this cancer? It brings up an intensity of care that is completely unnecessary. It is costly. And remember, this is not only costly for the insurance companies, this is costly for all of us, because healthcare is one of the drivers of the American economy. Our costs are just unsurmountable. And I do believe this is an important factor, and reforming this system, it's probably not going to be the panacea of reducing costs, but definitely needs to be part of it. I want to bring here the following point. If the doctor is practicing medicine within the standard of care, following what science dictates, what the medical literature dictates, the doctor shouldn't be liable. And unfortunately, our legal system is framed in a way that customary practices are followed instead of this other way of actually rewarding and protecting practitioners when they are practicing medicine within the standard of care, following what medical science informs us.
You know, you're 100% correct and accurate. And you know, what's amazing is that you are describing exactly the way I feel. I mean, the exact same situation, even though we are practicing in different areas. So, you know, just lets you know, it confirms that this is a problem. And for those of you who are in other countries, we're mainly talking about the healthcare system in the United States, the legal system in this country. But it's exactly what you have just been alluding to. It's not just sending a patient to the emergency room or sending them to the hospital. It's everything that is tied to this. You know, the imaging testing, the risks associated with these imaging tests. You just brought up the unexpected findings, which we call in medicine an incidentaloma, because it was something that was found incidentally. And then that merits a full workup as well. And that leads to a whole cascade of specialist consultations, procedures, biopsies, unnecessary imaging, which a lot of times really leads to nothing. But we are obligated to work these up. So, you know, I agree with you. I mean, it's a problem.
I wouldn't like the audience to get the sense that we are advocating for a lower quality of medicine in order to reduce cost. We're not talking about that. We're talking about following standards that actually have demonstrated better outcomes time and again. People need to understand a lot of care, too much care, not necessarily means better care. A lot of 100%. Times it's really bad. Yeah.
On the contrary, it's bad medicine, because I know that I don't want a lot of these tests performed. The word is unnecessarily. testing a patient. That is not good medicine. So no, you bring up a very good point. I don't know how you feel about that, but I feel it's quite sad that we have to practice this way. I just
You put the example of the DVT. I can give you another example. Somebody with a headache that presents to me in the office, and I know that this is probably a tension headache. The patient has been under a lot of stress. The headache is located in one area, doesn't have certain characteristics, doesn't have associated symptoms, has a completely normal neurological exam, but is under a lot of stress. This is probably a tension headache. You tell the patient to take Tylenol, do relaxation techniques, take it easy, and send them home. But you're tempted to think, well, what if he has something that I haven't detected? Let's say that patient, you
brain
do that.
tumor.
Exactly. You send it home, and the patient has a growing mass in the brain, and that's a negative outcome that it's very rare, it's super rare, but we cannot be being out there doing scans on everybody, because in order to pick up that person that had this tumor with this headache, which is completely atypical for that particular pathology, we would have had to do like 2,000 scans and irradiate the entire population. So, and that's negative. That is negative. So I don't know, Eloy, if you have looked over some states in the country that have adopted some sort of reform on this. And I was reading through, preparing to our conversation, and I saw a couple, but if you want to gloss over that, I'll be happy to share with you what I found.
Oh, yeah. I mean, it's exactly as you stated. I mean, there's a lot of controversy when it comes to this, because, I mean, how can you actually, and if you think about this, how can you quantify in a country as large as the United States of America, the impact that tort reform can have on healthcare savings, performing good medicine? I mean, it's very difficult because it's multifactorial. There's many different ways that you can quantify this. And a lot of times it's not very simple. It's not, there's no real easy way to go about this. And I think that that's what makes it so difficult. So, for example, and these are just general broad numbers, but, on a state by state basis of tort reform that has been passed, which of course we know has been passed in some states, but not others, there's pretty much somewhat of a consistent 3 to 4% reduction in healthcare costs. But the problem is that this has not been consistent. Other states have shown that, or suggest that there may be less than a 1% improvement in healthcare costs. So, which data is more accurate? I mean, which way are you going to go? I mean, alluding to what you were talking about, Texas, very famously passed tort reform, which was a multifactorial type of tort reform, mainly on non-economic damages, but they did see certain improvements after that cap was implemented. For example, they saw in one academic center, and I think this is meaningful, they saw that malpractice lawsuits decreased from 40 to 8 per 100,000 procedures performed. I mean, that's not a small number, And on top of that, in that same center, the annual liability cost decreased from $595,000 to $515. I mean, again, it just shows you, to me, just quickly glancing at this literature, it lets me know that the majority of the lawsuits prior to the implementation of this tort reform were frivolous lawsuits.
Paradoxically, the academic literature doesn't support the intuitive thought that this way of practicing medicine is just unsustainable cost-wise. Because the large-scale studies that have been done actually demonstrate that the decrease in general costs is minimal or marginal at best. And I ask myself, why would this be? This is contrary to what I see every day and to, I believe, most of practitioners in our country see every day. And I think, Eloy, that this is due to the fact that to change behavior in the physician community, it is hard. It requires time. And we see it with much more measurable things, like, for example, a change in treating a disease. You see that physicians, in spite of the medical literature, in spite of the article that came up in the New England Journal of Medicine, in spite of guidelines by medical societies, some physicians take longer to adjust and come to that type of practice. And I would say that in this topic, it's particularly harder, and we cannot pick up that with one study or with two studies. It's a longer observation that I think that needs to be done. I was happy to see the 2024 American Law Institute restatement of medical malpractice law explicitly incorporates, this is important, evidence-based practice guidelines as a defense, assuming courts find the guidelines relevant and authoritative. This represents a significant shift towards protecting physicians who practice according to current scientific evidence rather than merely customary practice. That is exactly what I was telling you at the beginning. And it was interesting. And I don't know, this American Law Institute apparently is a very authoritative law organization that a lot of people follow, is formed by judges, all right, that somehow dictate the way law is practiced in the United States. But how is that going to manifest in a little town in Georgia or here in Florida? How do we know that we are protected if I just follow the guidelines and do what's right for the patient and within what is scientifically sound? That's the question that I don't know. And I don't know if you have any thoughts on it, but I think it's important to touch on that.
I mean, what you're saying in theory is wonderful. That's the way it should be. But I mean, how do we implement this in the real world? I mean, you know, number one, medicine is very difficult. I mean, Manrique, you know this. I mean, I'm an oncologist, and it's hard for me to stay up on my own literature. I mean, I'm constantly reading, and since medicine is consistently evolving, you have to stay on top of things. And medicine is very, very difficult. It's very complex. And on top of this, you know, when you're talking, you know, applying this in the legal system, you know, in medicine, whenever you're talking about a medical malpractice case, you know, it's in an ideal world, it's because you have a physician that has not practiced what is considered standard of care. I mean, we agree?
100%.
So how do you define standard of care within a legal system? And I'll tell you what I mean by this. I'm going to ask you a question. Do you know what it takes to become a juror in a medical malpractice case? Think about this. This is a fundamentally important, or the most important question when you're talking about medical liability, because you want to know, did this doctor do something wrong? So if a doctor gets sued, the jurors, what qualifications do they need? I mean, do you know?
No, I have no idea.
You know, I looked this up, and it's laughable and it's offensive at the same time. You have to be at least 18 years of age, dominate the English language, in other words, be able to write it and read it, and you have to have a valid driver's license. That's it. Think about this. You do not require any medical knowledge. So I want to ask you, how is a juror going to be able to understand, deliberate a medical malpractice case if they have no medical knowledge? And I'll tell you something, and again, this is just my opinion. This is the way lawyers want it to be, because it works in their favor. Because you know what? This is where you run the risk of having a runaway jury, where cases are judged based on emotion, based on things that have nothing to do with the relevancy of the actual medical literature. And how do you interpret what you just stated? You know, how do you apply that a doctor cannot get sued if they practice standard of care? I mean, who is defining standard of care to be able to understand it and make a correct medical judgment?
It is super hard. I really do not have the answer to that. It is really scary what you said about the jurors that participate, because remember, when you're litigating one of these cases in court, the evidence is presented by the plaintiff and the defendant by lawyers. They will paint different pictures.
Correct.
Emotionally, how does who will emotionally touch that jurist's heart will be determinant on the future, not only of that physician's license, but also the lifestyle of himself and his family. And it's just not fair. Because,
Correct.
and I think that something occurs to me now. Maybe state medical boards need to, we need to expand their ability to do something with physicians that do not practice within the standard of care. But at least there, we are judged by our peers. That,
Correct.
because we're not, and let me be clear, we are not saying here that physicians, irresponsible physicians, or physicians who take irresponsible actions shouldn't be liable and, by things that they do wrong. Just the opposite. Nobody wants that. We want a system that is fair, that controls cost, and that is at least something that makes sense, because this stuff is just crazy. It doesn't make sense at all that somebody with little qualification will understand the scope of a guideline, medical evidence, customary care, standard of care, medical studies, randomized control trials. That person will act on emotions. I have no doubts in my mind, Eloy, that this increases, and that these at least need to be part of a more comprehensive approach. Definitely is not what's gonna fix the problem. I'm not saying that, but it's not fair to doctors, it's not fair to patients, and it's not fair to the country. We can have aspirations of growing our society, our economy, if healthcare costs continue to be such a high percentage of GDP as it is nowadays. The general public needs to understand that this not only affect doctors, it affects the way you receive care.
Oh, absolutely. And like we stated, it's a problem. And you stated the key word, fairness. Fairness is what needs to be sought, because at the end of the day, this affects all of us, and it, there's so much there in what we've gone over. For example, you stated it's not just implementing tort reform. It's also re-educating physicians to get into the habits, because we are creatures of habit. And we've been practicing medicine for a specific way for years. And I mean, if all of a sudden you implement a new tort reform and within 1 or 2 years, you look at the data and you say, well, you see, healthcare costs have not really diminished by much. Yeah, of course, we have to change our patterns of practice. I mean, and you're not going to attain this overnight. It takes time. We have to retrain the community, the way we practice medicine. I mean, listen, it's a problem. It's definitely a problem. Now, the key question is, what do we do? And, Manrique, the issue is the following, and I hate to say this, but we have to be honest with ourselves. The majority of our colleagues, the majority of doctors do an excellent job.
Yeah.
But some of them do not. I mean, I've seen it myself. I've seen some doctors that I really question what they're doing, and it's upsetting to say that. Now, I do want to say that it is a small number of physicians, but a few nonetheless. So I think in a fair system, a fair society, we have to have checks and balances. And the fear of lawsuits do keep doctors in check. The problem is in too much check, per se, that we are ordering way too much unnecessary tests. And we both agree that a lot of times we are hurting, not helping patients. And that is not good medicine. So the problem is, how do we find that balance where doctors practice good quality healthcare, but the legal system is not abusive, and finding that right area where we attain this is no easy task. I think, what I propose is one of the first things that has to be done is the jury selection. I mean, we have to be judged among our peers, doctors, nurses, nurse practitioners. I mean, we need people that can be able to have some level of knowledge of what standard of care means. Because if you do not have this, then you know what? It's unfair to begin with. I mean, you're not starting through a fair process. And I think that that's the first thing that has to be done. The other thing is when it comes to these payments, they're based on economic damages and non-economic damages. I mean, how do you put a price on pain and suffering? Because
Can you
the
explain that?
economic, sure, absolutely. So when, let's say, as a physician hurts a patient for whatever reason, let's say it results in the death of a patient, unfortunately. Well, that person, probably had a job. How much was that person generating? What was that person worth? So that is the economic damage. So let's say if that person had a job that they were making $100,000 a year, and that person was 35 years of age, that person was bringing home to that family $100,000 a year that family used to live. And all of a sudden, if that person dies, then that money is not going to be going into that family. So that's a tangible economic loss. Now, non-economic is pain and suffering. I mean, how do you, let's say a person went through a lot of pain and suffering because a doctor did the inappropriate thing. I mean, how do you put a price on that? And if you don't have a cap, you can have a jury or a case that says, this person's pain and suffering deserves $100 million. I mean, something crazy. And we have seen what's called, these runaway juries, if you will, where they're most based on emotion and not truly the merits of the actual case. And you're going to tell me that this doesn't increase healthcare costs? I mean, when you have these runaway juries, us doctors, we hear about them and we panic. And you know what that does? Our practice habits absolutely change because, for example, if it's a cancer case, as an oncologist, we all hear about this. And you know what we're going to start doing? We're going to start ordering all these unnecessary tests because we are afraid.
Thank you for clarifying that. I didn't have that clear, the non-economic and the economic part of the compensation that people are entitled from a medical lawsuit. You know how likely a doctor throughout his years of practice is to be sued? It's close to 70%. It means that
70%?
70%.
Wow.
It means that if we stay in practice, our likelihood, we're very likely to be sued if we stayed in medical practice for a substantial amount of time. When you look at the high-risk specialties, like gynecologists, for example, the numbers are much higher. Gynecologists are like 95% likelihood. That is unbelievable. That's something that to me is unsustainable.
100%. I mean, and you're going to tell me, I mean, and I want patients out there, the community to understand, you're going to tell me that this does not put a strain on the doctor-patient relationship when you're seeing a patient that that interaction, that 5, 10, 15, 20 minute visit that we have or whatever, that a potential multi-million-dollar lawsuit can arise from this. I mean, you're going to tell me that doesn't put a strain on that relationship? Of course it does.
It does. A lot of people, it depends on the person, right? And it depends on the professional. It depends also on the patient that you're treating.
And it's amazing because, we share sentiments. I mean, it's an absolute fact, and it, unfortunately, we're human, and it does affect the way that you perceive a potential interaction with a patient. I mean, it is what it is. And what saddens me the most is, before I became a physician, I could have done something else. I mean, I believe I chose the hardest career, the career that I knew I was going to spend my entire youth studying to be able to be mentally and physically able to care for patients, which I thought there was no more noble profession than medicine. And then when I went out to the real world and I saw this, I said to myself, but wait a minute, I took an oath to help patients. I mean, and I take pride on this, and we collaborate. We take care of patients together. And I know you're one of you practice the same type of medicine I do. We want to do the right thing, but it's also sad that we have to have this dark cloud over us where we feel that we have to practice this, CYA, cover your behind type medicine because of the fear of lawsuits. And I really do hope that someday, this can be at a minimum diminished,
And people need to understand that this is only one of the aspects of the complexities of our daily practice. There is and probably this is a topic for a future conversation between you and I, the topic of career satisfaction and how happy are we of being doing what we're doing, because I think there is a conflict between the principles of our profession of medicine, like an art, and the priorities and the principles of the system we work in. And if you add to that, to those pressures on the coding and billing, on the stuff that we have to do every day that has nothing to do with what we had in medical school, what we took in medical school. We didn't go to coder school. We didn't go to provider school. We went to doctor school, medical school. And a lot of times we find ourselves in our daily lives doing stuff that has nothing to do. We didn't sign up for this. We didn't sign up for this. My career satisfaction depends on the satisfactory hours I spend with my patients, on the outcomes that I get when I treat somebody. That gives me satisfaction. It doesn't give me satisfaction.
And I'm sorry to cut you off, just to what you're alluding to. And the crazy thing about it, Manrique, is that patients have no clue that this is happening. They have no clue because, the general perception, and again, I'm generalizing, you should never generalize, but the general perception is that we are extremely happy and we are all multimillionaires. I don't know about you, but I have a money tree in my office. I can pull $100 bills. That's the perception. And you know what? Times have changed. That's not the case anymore.
It does. And I think that's a topic, Eloy, that we should take in the future. Career satisfaction, money, medicine. Are we really rich? That's a topic that we need to have a conversation on. And I'll be happy to join you and continue to doing these productive talks between you and I. And I think it's can illustrate to the public, the honest conversation between two practicing physicians that just want to share part of our lives.
Absolutely. So we're going to do that. We're going to collaborate. Well, these are interesting topics. Now, I just want to add, for those of you that are viewing this video, give us your input. Do you agree? Do you disagree? Do you have something to add? Very important. We take pride in reading our comments, responding to our comments. We're not only here to give our perspective, but we're also here to learn. If there's one thing that we never stop doing is learning. So, Manrique, thank you so much for being a part of this. Anything else that you want to conclude with?
I want to close by saying that sharing with somebody like you these thoughts for me is extremely enriching and something that I can do all day besides practicing medicine. So thank you for sharing these minutes with me.
You got it, my friend. All the best to you and your family.
Take care, Eloy.